Good afternoon all. As Gail kindly said, my name's Anna. So I'm a nurse practitioner. I finished my nursing training about 8-9 years ago now. I then went through and have completed my nurse practitioner training about 18 months ago. I was lucky enough to be dual trained as a primary care and palliative care nurse practitioner. I worked for 2 years with Totara Hospice. So I did my training through Totara Hospice and then worked for another year there. And I've recently left there at the end of last year, and I'm working for a primary care group in Auckland. And part of my contract with that primary care group is caring for a residential care facility in Manukau, which is predominantly dementia care. It's got 45 dementia beds, 15 psychogeriatric beds, and 55 hospital beds. But as you would know, most of those hospital beds are patients who've been in the dementia care unit but have then transitioned out when they've become non-mobile. So I've had a crash course in end-of-life dementia care over the last 6 months, which has been huge. And I was very honoured when Gail and Kathy came to me and said, would I be happy to present to you guys today? What I'll be talking about is pain at the end of life. Which is a huge challenge for us working in residential care in general, but particularly in dementia care as it'll become apparent. So looking at palliative care, what is palliative care? I guess palliative care, we say no matter who we are, no matter what our background, we all are eventually going to face death and dying. It is the final journey for all of us. And palliative care has traditionally been very much about physical symptom management, but it's broadening more. It's more about quality of living now, optimizing that quality of life as much as possible, addressing both those physical needs, but also psychosocial, spiritual and cultural needs to make the person's journey, but also their whānau journey as comfortable as possible. And what I commonly hear people say to me when I say, we need to switch to a palliative care focus, they say, but my patient isn't palliative, they don't have a cancer diagnosis, etc., etc. But actually palliative care is no longer just around cancer. And I say to people, would you actually be surprised if this person died in the next 12 months or in the next 3 months or even tomorrow? But if not, then actually palliative care is a perfectly reasonable route to take. This is an amazing resource that I think all residential care facilities should have a copy of or have access to. It's the Palliative Care Handbook. It's published by Hospice New Zealand. It's based on an Australian handbook, but it's been adapted for our New Zealand environment. You can still get these hard copies. They're a little bit few and far between, but there is an electronic version available on the Hospice New Zealand website. It is really, really good. It is aimed at palliative care physicians or palliative care clinicians, so nurses, nurse practitioners, GPs, palliative care doctors, but it's got really good information in it, not only about medical management, but also about non-pharmacological management, things that can be done, and it's really, really useful. And so when we talk about palliative care, you think about palliative care as being, I guess, predominantly symptom management. And this is a list of various symptoms that are in this handbook that are things that might become an issue in people's last months, weeks, and days. And looking at that list, that's a pretty wide-ranging list of different things. And some of those you might not see very frequently. You might not see terminal agitation. You might not see fungating wounds unless you've got someone with, oncology, malignant problems. However, these ones that I've underlined here are those ones that even in residential care with patients with dementia or no kind of malignant concerns, no cancer concerns, those are things that we see day in, day out with our patients. We see delirium, we see depression, we see insomnia. Constipation is the bane of our existence. Nausea, vomiting, pressure areas, and particularly pain. And that is a huge one. And it becomes more important, particularly in patients with, assessing in patients with dementia. So pain, this is the International Association for the Study of Pain. This is their definition. It's an unpleasant sensory or emotional, note that word, experience associated with actual or potential tissue damage or described in terms of such damage. It's very individual pain. It's very multifactorial. Every single person will have a different, what they perceive pain to be is different. How they feel it, how they express that pain is completely different. And there's a lot of different sorts of pain. You can have acute pain, so sudden onset, chronic, it's been going on for a long time. It's constant, it's there all the time. It's intermittent, it comes and goes. There's different types of physical pain, so somatic, visceral, neuropathic, I'll come to those in a moment, as well as emotional, psychological, and spiritual pain, which, you know, are incredibly valid as well and can worsen or alleviate physical pain as well. And there's the reason pain is particularly important in the area of dementia and cognitive impairment is that there's new evidence coming out kind of in the last 3 to 5 years that patients with cognitive impairment may have increased responses to pain stimuli, as well as you will all recognise a decreased ability to communicate their need for analgesia or other management. And these kind of increased responses can come under a couple of different things. One is hyperalgesia, so the standard stimuli that, you know, anybody would respond to, they can have an increased sensitivity to that. And there's also something called allodynia, which is a non-painful stimulus, so even just gentle pressure and things like that sometimes can give a really painful response. And so those pathways that lead to response to pain can be really, really altered in patients with cognitive impairment. And there's really good research going on now about that. And for that reason, 70% of patients with significant behavioural and psychological symptoms of dementia can, in various research, have undertreated or unrecognised pain as a contributing factor to that behaviour. And it's something to bear in mind. Are we treating pain with antipsychotics because we're seeing it as BPSD, but is this actually underlying pain? And so for this reason, it's really, really important to make sure we're doing really effective pain assessments for these patients. And so looking at pain assessments, I guess, you know, the easier one, in inverted commas, is reported pain. So those patients who are verbal or partially verbal are able to communicate some or all of their needs. Then it's easier, that supposedly is the easier one. You know, you can ask some questions, it might be reworded, it might be using their own words, but you will be able to get responses from them. So, you know, this is PQRSTU, this is an alternative to the old CARTS, one that many of you will have learned about in various studying sessions. This is kind of I like this one better because it's a little bit more normally worded, if that makes sense. So, you know, things like what makes it better, what makes it worse, use, you know, finding their words for what this pain is. Is this an aching, throbbing, gnawing pain? Is it a deep ache, dull pressure? Is it a burning pins and needles pain? Is it just a deep, deep pain right in their bones? I remember I had a patient last year who described, she had cerebral secondaries, and she described her pain in her head as kauri roots boring into her brain. And if I, you know, when I realised that that's what she was explaining, then the whole process went much more easily, because I was able to remember those words and use them back to her when I was talking to her, being able to differentiate her different sorts of pain. So the radiating, the severity. If they can't do a numbered scale, there's lots of other scales that you can use. There's the one with the faces and various other things that you can use. Does the pain come and go? That's quite an important one, because there's two sorts of pain that does come and go, and that's breakthrough. So it just comes with no kind of trigger. So it can breakthrough through the analgesia that's already there, or incident pain. So it's triggered by certain movements. It might be triggered by doing cares. It might be triggered by trying to move their legs, those sort of things. And then kind of the understanding, actually, what does this pain mean to you? Does it have some relationship that, you know, certain cultures have meanings for pain, and they're there for a reason. Actually, do you have a belief that what is causing this pain, is this affecting your life? Is this something we need to deal with? So that's a really kind of good basic pain assessment to use. The more tricky pain assessment can be those for people who are non-communicative for various reasons. This might be a language barrier, which we're finding more and more and more in New Zealand as we become more multicultural. You know, we're getting a lot of older adults who don't have English as their first language and may have very minimal English to communicate their need. And then there's those, like many of our advanced dementia patients, who just don't have the words anymore. And so it's this observed pain. And nurses, you know, your care staff, patients, family and whānau, their visitors are all really valid and reliable observers. And actually sometimes the whānau can be the most useful because they know these people really well and have often known them for 10 years before they've come to you. And same with the nurses and the care staff, you guys have known them often, you know, they've been with you for 5 or 10 years, you can know them really, really well. And so, you know, trust your gut. Those behaviour changes of being withdrawn, agitated, angry, aggressive, resisting cares, really, really restless, moving their legs backwards and forwards. Those are really valid triggers that maybe we should do a full pain assessment. And this is the Abbey pain scale, which was designed specifically for people with dementia. And I didn't realise that this actually existed until relatively recently. I do this without even realising I'm doing it. You know, looking for vocalization, facial expressions, changes in body language, behavioral changes. Is their blood pressure sky high? Are they tachycardic? Have they got pressure areas? Are there things like that? And adding those up, going, okay, actually, this is something we probably need to think about. And the other part of a pain assessment is more than just that. It's looking at what other things could be making this pain worse. Are they constipated? Is that why they've got tummy pain? Are they actually in urinary retention? Is that why they've got abdominal pain? Have they got an infection? Have they got a urinary tract infection or a cellulitis? Are they not sleeping, which is making this pain worse? As many of you will know, if you have a really poor night's sleep, your ability to cope with anything the next day is affected. Is there a depression and anxiety, ruminating? Is this making the pain much worse as well? And then also a physical exam. So is there peripheral neuropathy? Have they got decreased sensation or the hyperalgesia that we were noting before? And if they were complaining of tummy pain, have they got an enlarged liver, which can happen as well? And the reason you want to look at that is to work out what type of pain. And also in there is investigations, if appropriate, blood tests, x-rays, those sort of things. But I'll come to the if appropriate part in a minute. The other part of it is the more holistic part. So is there an emotional aspect? Is there fear, anxiety, sadness, anger, frustration? All of those things are going to worsen the perception of the pain. Are there spiritual needs being met? You know, you might need to check with the whānau as to the background for them. Is there an existential distress? Is there, you know, people often have a perception of end, depending on, you know, their culture, their religion, their spirituality, they may have a perceived need around end of life processes that maybe we're not meeting. And the other thing with whānau is there someone you're waiting for? You'll all know those patients who hang on and hang on and hang on despite how much pain they're in, etc., because they're waiting for someone in particular to come or waiting to settle some unfinished business. So all of those things will affect pain. And so once you've gone through a full assessment like that, you reach a decision point. The first part of it is around the cause and the type of pain. The reason it's quite good to know what we think is causing this pain is to be able to treat it appropriately. If it's a disease-related pain, like bone pain, nerve pain, neuropathic pain, liver capsule pain in someone with liver disease, raised intracranial pressure with awful, awful headaches, underlying arthritis or osteoporosis, so maybe they've got fractured bones. Is it treatment-related? Are they constipated because of the medications we've been giving you? Is there a mucositis for someone who's not eating very well? And then there's the ones that just go with debilitation and frailty, so pressure areas, cachexia and candidiasis. And the last kind of step of this is the goals of care. So talking to the patients and the family around a ceiling of, not a ceiling of care so much as where do we draw the line for active treatment? Where do we say, actually, we're moving to palliative management? We're not going to transfer these people to hospital. These people have often been living with us for a number of years. This is their home. They don't want to go and die anonymously in a big hospital with nurses that don't know them. You know, it's better to be able to keep them in your facility where you got, you know, where we can look after them really well. And actually we can do most, you know, we can do best practice pain management. We can do best practice symptom management as easily at home, which, you know, whether their home is their own home or whether it is the facility, residential care facility, you know, that's where we want them to stay. As if we can. The hospital's not a good place to be, particularly not at the moment, and it's not somewhere you want to be sending people if you can manage it. And the other thing is having a discussion with the patients if they're capable, but also with the whānau around, are they okay with the fact that their family member might be a little bit drowsy, but actually their pain will be much better managed. I often get kind of sometimes a cultural pushback at this point where, you know, people worry if we're going to be giving them, you know, good pain relief and things, is this hastening the end? And it's not. It's keeping people comfortable while Mother Nature takes its course, or while, you know, we're leaving it in God's hands, depending on the people's beliefs. I don't judge on beliefs, but it's depending on what their beliefs are. We're just keeping people comfortable while, you know, the natural process happens. And often if people are more comfortable, sometimes things do happen quicker just because they're not fighting that pain, but then they're not distressed and the family aren't distressed. So if we're looking at managing pain, there's always that non-pharmacological stuff. And actually this can go a long way for a lot of people. Reassurance, yes, you know, validation, yes, this is real pain and there is something we can do about it. You don't have to sit here and suffer. Amazes me how many people have the perception that they just have to live with pain. And reassuring the family that there is something we can do about this as well. There's always the one I always harp on about, which is positioning, making sure people are being repositioned regularly, turning them if they'll allow you to, making sure we're dealing with their pressure areas. Physiotherapy input can be good for some people as well. You know, mobilization, if they're lying in bed all the time, your joints get incredibly stiff. You imagine even if you've had the flu and been in bed for a couple of days, you wake up and you ache all over and it's just not moving. And so physiotherapy can be helpful even if we're not getting them out of bed. But for those who can get out of bed, sometimes getting them up and moving them a little bit can help with the pain. Massage or miri as appropriate, that can be really, really helpful. You can get the family involved in that. Gentle massage can be really good. Heat packs are particularly good. I know some facilities have a problem with hot water bottles, but I do think, you know, if the nurses are managing using heat packs, particularly in musculoskeletal pain and also abdominal pain, visceral abdominal pain is really important as well. Distraction, you know, having music playing, those sort of things, having the family there sometimes can make a difference as well. Prayer, if it's appropriate, you know, having their family come in and pray with them, or their religious people, leaders come in and pray with them, can be really valid, particularly for people who have got existential suffering going on. And then traditional medicines, I didn't know whether to put this under non-pharmacological or pharmacological, but there are a lot of families who like to use traditional medicine alongside Pākehā medicine, and I think that's perfectly valid. I do just ask that they talk to us about that. Always when I think people are heading down this route, I always say to them, look, is there anything you want us to be aware of and want it to be valid? Because I just want to know what you're giving them so that I don't give them something that makes them incredibly sick. But traditional medicines are perfectly valid as well. And there is increasing research and evidence around the interactions between, you know, available data around interactions and what not to mix of our, you know, mainstream medicine with traditional medicine, particularly around Māori and Pacific medicine now. So next step when that's failing is what we call simple analgesia. So that first step on the WHO ladder, I meant to put the WHO ladder in here and forgot, but you know, that first step of paracetamol or non-steroidals is appropriate, but particularly paracetamol, it's really good for that baseline pain. It can be used every 4 to 6 hours, so you can use it as needed or regularly. You can give it as tablets, you can give it as elixir, so the syrup if people aren't swallowing the tablets, or don't forget about being able to give it rectally. It's really, really good. Also, if people have got a pneumonia or something like that, using it for the fever as well. One of my nurses complained recently because I was giving it the patient paracetamol every 6 hours, including at 2 a.m. But they were much more comfortable when we did that. We didn't have that breakthrough overnight where their fevers spiked in the middle of the night. And always think about, you know, if somebody's lost a huge amount of weight, make sure you raise that with your prescriber, that maybe we need to reduce the paracetamol dose as well a little bit. Non-steroidals, they work really, really well. Things like ibuprofen, diclofenac, naproxen, they don't have a huge amount of use with our elderly patients, mostly because a lot of them have got renal impairment and they have to maintain a good fluid intake. But also the topical diclofenac can be quite good, kind of short-term use for musculoskeletal pain. I had a gentleman recently who ruptured his biceps and he found that really, really good. Next step, if this isn't working, next step on the WHO ladder is the non-opioid medications, so codeine and tramadol. They can be useful for some people, but they've got real limitations in our older adults. Codeine, as you'll know, has mixed use for some people. There's a huge variation in metabolism. 10% of Caucasians, it's absolutely not effective for them. They don't have the enzyme that allows them to metabolize it to morphine in the body. It also is affected by SSRIs, so the things like citalopram and those sort of things, which a lot of our older adults in our care facilities are on. It can mean that codeine just isn't effective at all. Also that bane of our existence, of it's actually much more constipating than morphine. So often if they're needing this, maybe we need to move to opioids. It can be good for osteoarthritis particularly if they've used it before successfully. The other one that's on this step is tramadol. Unfortunately, it lowers the seizure threshold, which for our older adults with Alzheimer's, with dementia at all, often they've got a lowered seizure threshold anyway, because of the brain changes, and a lot of them have had seizures previously. And again, it can't be used with SSRIs. I also get a lot of patients tell me it just makes them feel weird. They can't exactly stick their finger on it, but it makes them feel weird. And so commonly the next step for most people, if the pain's not being well controlled just with paracetamol and non-pharmacological stuff, is the next step is opioids. Unfortunately, at the moment, we don't have any kind of in-between step. I often get, particularly in South Auckland, where we're really, really multicultural, we've got a lot of Māori and Pacifica people with very differing health beliefs. I often get a bit of a pushback around opioid analgesia. There is a belief that there's also a lot of belief out there that you will get addicted to it very easily. And I had someone explain it to me really well a while back that, you know, when there are the pain parts of your brain, so in this picture, that these pain parts are completely different to those parts that are the reward parts of your brain, so the parts that are around the side effects and the addiction potential of the opiates. So if there are really, really active receptors in these parts of your brain that are responsible for pain, that's where those opioids are going to work. It's only when you don't have those pain pathways active that the opiates end up working at the other parts of the brain that are responsible, for example, respiratory depression and the reward pathways. So often I can reassure people that actually, and you know, it's about using appropriate doses as well. We're not just going to ramp the doses up and up and up and up, which is often what happens in people with addiction. And so the first step in the opioid analgesia is either morphine or oxycodone. Every prescriber will have their preference. Some will use morphine first, some will use oxycodone first. There's mixed evidence around whether oxycodone is better in patients with renal function, but I do find that our older adults tend to have less side effects to the oxycodone than they do to the morphine. But if people have had morphine before successfully, we'll use that as well. They can be given either orally or subcutaneously, and I will come to the subcutaneous administration of these analgesics in a couple of slides. But as an oral form, again, they're available in both short-acting and controlled release, and the short-acting is available in both a tablet and an elixir. And I do quite like using the elixir to start off with for a lot of people. You can start really low. You can just use 1 or 2 milligrams as needed, you know, for breakthrough pain, for that incidental pain. You know, if people are getting a lot of pain just with cares, but they're actually really comfortable the rest of the time, being able to give them a couple of milligrams of something 20 minutes before cares, so that you can get them through that time, that painful time. And that can be really, really useful. And again, you know, once they're getting through needing regular PRNs for that sort of for oxycodone or morphine, then you can step up and use a kind of twice daily controlled release as well. The other medications that come in this group that you may see used are methadone, which, you know, we all traditionally think is something that you use for narcotic dependence, so people who you're trying to get people off heroin and things like that. But it has a really good place in palliative care for pain management. So particularly for people who are really needing really, really high doses of morphine and oxycodone, so they've got a tolerance to it over time. For example, if they've been in a car crash years ago, and so actually their body's used to these sort of medications, it can be really good. And it's also really good for renal impairment, but it's got a very long half-life and a very variable half-life. So it can be quite difficult to titrate for some people. But it is worth, you know, it is something that you might see come up, particularly if patients are under hospice care as well. They use it a lot. The other one is fentanyl, which has got a bad rap internationally because it's got an abuse potential, particularly in America. It's a synthetic opioid, and it's got a potency 100 times that of morphine. So you will see it prescribed in micrograms, not in milligrams. So that's not a typo. It is something that is prescribed in micrograms, not milligrams. It's really good in renal impairment and renal failure because it's cleared by a different route. It's got really rapid onset, but it's got a very short half-life. So we use it in a number of different ways. I quite like using it. You can use it transmucosally, so intranasally, or and using, like we'd have a midazolam nasal spray, you can also have a fentanyl nasal spray, and you can just spray it into their cheek or up their nose. It's got a really, really rapid onset, quite good for that incidental pain. It also comes in a transdermal form, so as a patch, which is how you get around the short half-life. Those patches you've got to be really, really careful with. A couple of things particularly to note about them: you can't cut them, it affects the absorption, and you've got to make sure that when you peel them off that you stick the faces together and you dispose of them really carefully. Patients also, if they're changing themselves, need quite good education around it. I had a patient who was chewing theirs, so that was a little bit terrifying. So that transdermal, the fact that it's changing every 72 hours can be quite good. It just gives them baseline. So you might see patients come through with that as well. And then also fentanyl can be used subcutaneously, so we often put it into the syringe drivers. So those are the different opioids that we use. On top of the opioids, there's also what we call co-analgesics. So these are often used in specific circumstances. So steroids are used a lot. Things like prednisone or dexamethasone, particularly used for inflammatory pain and swelling. So maybe raised intracranial pressure. If we've got brain metastases or something like that, we might use dexamethasone to bring that down. Rheumatic disease, so rheumatic arthritis and things like that, often when people can no longer be on their disease modifying agents like methotrexate, we might change them back and use some low dose prednisone or even high dose prednisone. In the grand scheme of things, we're talking about symptom management. We're talking about quality of life, not length of life at this point. So if they actually need to be on 5 or 10 milligrams of prednisone a day, then that's okay. That's not actually an issue. The other thing that the dexamethasone is used a bit for is liver capsule pain. So people with liver disease, as the liver grows and stretches, it's bound inside a capsule, and that capsule is covered in nerves. And so as that liver grows and stretches, the nerves in the capsule, it causes incredible pain. And so the dexamethasone brings down that swelling and can make a huge difference to that pain. Also neuropathic agents. So for patients who've got quite significant peripheral neuropathy, whether it's secondary to diabetes or perhaps previous chemotherapy, or for whatever reason, that burning pain that they get in their feet, often worse at night time, sciatic type pain that runs down their legs from their lower back, from patients who've got spinal cord injuries or spinal cord disease. And patients often post a spinal cord injury, if they've got partial feeling, can get really awful neuropathic pain. The two different types of medications we use are either tricyclic antidepressants, so for nortriptyline or amitriptyline. Tend to prefer nortriptyline out in the elderly population. It tends to not quite have significant side effects. The amitriptyline tends to cause quite significant drowsiness. And the other group of medications is the gabapentin and pregabalin. Pregabalin's a newer medication in New Zealand, so you might not have seen it so much, but it's twice a day as opposed to gabapentin's 3 times a day, so it's much easier to give, and you can start really low and titrate up really slowly. So that can be really, really good, and they might not need much, but again, it's putting all these things together. A little bit of this and a little bit of that might be enough to manage the pain better. It might be a little bit of everything might be better than a lot of one thing. And the last thing that can be quite significant is muscle spasms. You know, for people with contractures or people who've got seizure activity and things like that, they can end up in quite a lot of pain from that. And that's where we end up maybe using benzodiazepines like your midazolam or your clonazepam, or potentially baclofen. You'll know that a lot of our patients are actually on clonazepam and lorazepam and things for behavioural issues. And so, you know, when those, as they become less mobile and maybe not taking these medications, then there's we can get breakthrough issues. The problem comes for all of these patients when they stop swallowing, which invariably happens for most people unless they die suddenly. Or most of our patients at some point will stop swallowing. And then we have to look at subcutaneous medications. And all clinicians are more or less comfortable with this depending on their exposure, but it is a good way to manage pain when they're not able to swallow or when they've got poor oral absorption. So people with bowel obstructions and things like that just aren't going to absorb their oral medications at that point. And so I've put this picture in here. These are the different places that you can insert your subcutaneous lines. You can just inject straight under the skin without a subcutaneous line, and if you need to. If you are putting in subcutaneous lines, this behind the shoulder blade point is really, really good for our dementia patients. They're less likely to be able to tussle with it and pull the lines out, particularly if you put the line this way with it hanging down. It's much harder for them to reach around. Places like tummies and legs, they tend to play with it. You can use under the collarbones in a pinch as well for patients who've got no tissue anywhere else. But a lot of these sort of areas, it's much easier for them to play with them. So often I try to get our nurses to use the back of the shoulder blade if it's something that they're likely to be playing with. Giving things subcutaneously, they can even be given PRN, so as needed as a bolus dose, and or continuously via a syringe driver. If you aren't familiar with using syringe drivers, make sure you either get some training either through your facility, through your organisation, or alternatively through your local hospice. All of the hospices run syringe driver trainings around New Zealand, and can help with that. The really good thing I like about using the subcutaneous administration or using the continuous drivers is that it's not just for pain management. You can also address the anxiety and distress part of it. You can address dyspnea, you can address nausea, you can address seizure risk, all in the one syringe driver, which makes everybody's life so much easier. And then, you know, they can be, those recipes for the syringe drivers can be changed as needed. And you can still give PRNs or boluses on top if you need it for the incident pain with the movement, or, you know, if the nausea breaks through, then you can give PRNs as well. So always make sure if somebody's prescribing one of your patients a syringe driver, that you have PRNs as well for nausea, for pain, and for distress. So making sure all those three are prescribed. And so, you know, when we're looking at other things that you might see in the syringe driver is for dyspnea, opioids work really, really well for dyspnea as well as for pain. And so often, particularly for people with heart failure, a little bit of an opioid can make a huge difference for shortness of breath, as well as the benzodiazepines, so midazolam and clonazepam. Don't forget about the intranasal midazolam. You can get them made up into a spray bottle, and that can be really good for, you know, people to use just before they get up to go to the bathroom. It's really, really quick onset. And for people who are a little bit more cognitively intact, they can actually self-administer that if they need. If patients are on oral anticonvulsants and they're no longer able to swallow those, you can start a higher dose benzodiazepine driver to manage that seizure risk, particularly for patients who frequently have seizures despite being on optimized management. I like to check with the nurses and say, right, this person's obviously no longer swallowing the levetiracetam. When was the last time they had a seizure? When do you actually think we need a driver for this? Or are you okay monitoring for a couple of days and we'll start a driver if we need? Nausea. We can trigger nausea with opioids, but also if they're no longer eating and drinking, they can get quite a lot of nausea. And so using either metoclopramide or haloperidol. I know haloperidol traditionally is we use as an antipsychotic, but at low doses, it can be really, really good for nausea as well. And then also it can do dual duty for kind of agitation, distress, hallucinations. It's not uncommon for people to get hallucinations in the last days of life. And so using a little bit of haloperidol or midazolam in their driver just to manage that, particularly if they're distressed by those hallucinations. If they're not bothered, if it's their ancestors coming to get them and they're really not bothered, I don't usually dose for it. But if they're really bothered by these hallucinations, it's the little men sitting in the corner or the people sitting on top of the TV, then actually, keeping them comfortable and undistressed is really important. And so this is kind of my last slide. And I guess my real message to all of the nurses and care staff working in residential care is advocate for your patient. You are your patient's best advocate when it comes to talking to your clinician, whether it be your doctor or your nurse practitioner or whoever. Ask for what you think you might need. If you think this person is starting to deteriorate, if your GP's in on a Monday and they're not back to a Thursday and you think actually this patient's deteriorating, rather than you having to ring them at 3 a.m, say, look, can you actually just prescribe some pain relief and some medications for distress if you think that they're hitting those last days particularly, or you think their pain is ramping up, make sure you get all of that prescribed. And then also making sure that if things are progressing, that you get their medications reviewed regularly. So if you're noticing needing 4 or 6 lots of breakthrough pain relief in a day, actually, do you need to increase the amount that's in the driver? Do you need to increase the controlled release, their morning and night medications? You know these people the best. You're watching them regularly. If there's not enough breakthrough doses, if you're only allowed to use 4 doses a day, but actually you need 6, ask for that to be increased. That's a perfectly valid thing to do. You guys are there all the time. You're our eyes and ears as prescribers. You know these patients the best. I have no qualms with my nurses ringing me up and going, something's not right with this person. And I trust their gut. They've known these patients often for 5 years or more. If they think something's not right, usually it's not right. And I go and review them. So just, advocate for your patient, advocate for their families. And so that's pretty much the end. And so has anybody got questions? I think there is one question up there that I can see. Oh, and on the end of this is a whole lot of references for people who want them as well.
A question came through about the Abbey pain scale. And the question was, how often would you redo that?
I would say every time you do medication rounds is probably quite valid. Once a shift, just make sure that, they don't need, if they're not on regular pain relief, I'd say when you're going around and giving them their regular medications, if they're someone who's not verbal and isn't able to say, I'm in pain, doing a quick overview, you just looking at those questions, and the more you do it, the more ingrained it becomes. Like I said, I do it without even realizing much of the time. So I'd say every time you go around for your medication, just look at them and go, actually, have things changed since the last time I saw this person yesterday, you know, or last week, or are they in more pain than maybe they're letting on?
Yes. The other one, actually, I've got an answer to, which was, how do you source that palliative care handbook?
Yeah.
And
so,
go on to the hospice website.
Yeah, if you talk to your hospice, your local hospice, they may still have some paper copies.
Yes.
There was a limited print run, and I think some hospices will have them sitting around that they might be able to give you a copy for your facility. But there is also a digital copy available. The other thing for people who have access to the community pathways, at least in Auckland, I'm not sure how it works outside of Auckland, but our community health pathways have a really good palliative care section as well for that sort of information.
Okay. Well, thank you, Anna. It's been a wonderful session, and you covered a wide range of things. And I know lots of people, it's very difficult when you're on your own there. And you know, you're looking at your patient and you're not sure, and
Trust your gut.
Yes, but it's the knowledge and the affirmation of what you've said that makes people confident. So I'm sure everyone that's been on today has enjoyed it, and I just encourage you, there is a survey available. We'd love some feedback, and if you just can fill that in, we're going to end the session now. So that's all from us.
Thank you very much.